by covering some anatomical considerations for implant placement when it comes to the mandible. So a couple of things to keep in mind here with the mandible when you're placing in the first or second molar regions. The superior border of the inferior alveolar canal is typically 3.5 to 5.5 millimeters below the apex of the first molar. So if the first molar apex is typically, let's just say if we guess somewhere around here, okay, we can assume that 3 to 5 millimeters below that is where this superior border will be. And that's kind of in line with what you see where the mental foramen exits here, okay? When it comes to the second molar, that distance from the apex to that superior border is less than with the first molar. So keep that in mind. Typically with the second molar, you will have less vertical height post-extraction versus a first molar, okay? So keep that in mind with the molar areas when you're doing implants. Now, if you can't visualize the canal with a PA, take a panel. If you can't see it in the panel, then do a cone beam. But you definitely want to visualize where that canal is so you know how much height you have of bone prior to any kind of implant placement in any dentulous area. Now let's move on to the mental foramen. Okay, so the mental foramen is usually located between the first and the second premolar. Almost half of the time, 44% to be exact, the mental foramen is found apical to the first premolar. In these cases, 46% of the time, or almost half, it is above the apex of the first premolar. 15% of the time, it is level or at the same level with the apex. And what's interesting is if you look at the mental foramen here, I'm going to try to really focus this. You can see it here. It goes in deep and then it makes a loop anterior and then it goes up. All right. So 61% of the time, that anterior loop that presents will go between 0.5 millimeter to 6 millimeters forward and then curve around. The panel will typically not show this, okay? So why is this important here? Because you want to leave 3 to 6 millimeters of clearance anterior to the mental foramen if you're placing implants in this area. So very important to be able to visualize where that landmark is, okay? Another important landmark on the lingual surface, okay, is the right here. So you can see the lingual surface and you can see this kind of bump here in the second molar area. So this lingual concavity here is very important because according to CAT scans, I think 103 in this one article, it showed a 66% prevalence of this lingual concavity or presence, okay, of this dip here. So why is this important? Because if you're preparing a spot for an implant in the second molar region here, okay, your angulation is very, very critical because if you angle it too far buccal, the apex will perforate through this cortex. And if this flap is not elevated above the bone, the sublingual area is heavily vascularized. So what does that mean? It means it will bleed like crazy. So very important when doing implants in this region to do a full thickness flap to your anticipated depth so that just in case you do perforate through any of this bone here, that if there's a very prevalent or prominent lingual concavity, that you won't perforate through the flap or any of those vascular or nervous tissues that are within the flap. All right. This lingual concavity, how often does it present, between the second and the first premolar? 90% of the time in the second molar area, as you can see here. And in the first molar area, you can see it kind of levels off, but you can see that dip here as you go further back to the second molar area. Okay. And the other area, the last area to be concerned with, is in the mandibular anterior region. Okay, right here. So the lingual aspect here is heavily vascularized as well. I would recommend any time you do a mandibular incisor implant, reflect the lingual flap to at least your anticipated drilling depth. Just reflect that tissue. You can use a spoon excavator, elevator, whatever you use, but I would say reflect that tissue on the lingual to your at least your anticipated depth, so that that tissue, in case you perforate, because the bone tends to be very thin to begin with here. All right, usually very thin. So if your angulation is slightly off and you perforate through that tissue, you will not injure the vascular tissue there and induce any kind of hemorrhaging in the floor of the mouth.